I've always said radiation oncologists and urologists are kind of joined at the hip, or you might say joined at the prostate. And I think any good radiation oncology program needs to update us on what's going on in the world of urology, and I think similarly what's going on in the world of radiation oncology should be of interest to this audience. So this is my update of what's happened in the past 12 months if you were sleeping. I have no disclosures, and again, anyone who wants to take a little side trip up to Sedona and pay us a visit would love to see you there. First question I've got is relating to the recently published ASCEND-RT trial. Compared to dose-escalated external beam radiation therapy, radiation with a brachytherapy boost does one of four things. A, it improves the 10-year biochemical control for intermediate risk but not high-risk patients. It improves the 10-year overall survival in all subgroups except low risk. C, it improves the 10-year biochemical control for all subgroups. Or D, it improves the 10-year biochemical control for all subgroups, but with a prevalence of 20% late GU toxicity more than 4 years out. So if you could choose your preferred question, A, B, C, or D. Okay, so the plurality seems to think that it improves 10-year survival with a prevalence of 20% late GU toxicity. That actually isn't quite right, and I'll show you the slides before we're done. Actually, group C is the correct answer, and I'll show you the slides on that as well. So, second question, relating to some recently published data from the RTOG 9202. Had a publication within the past few weeks that shows that with long follow-up, IMRT radiation to 73.4 in 8.2 weeks is superior to 70 gray in 5.6 weeks. Number B, 4 months of ADT is comparable to 28 months ADT for most endpoints, disease-free survival, cause-specific survival, and distant metastasis. Number C, overall survival shows a significant difference for patients only with Gleason 8 or above. Or D, most GU toxicity is seen in the first 5 years after radiotherapy. All right, so we're going to talk about that because in fact 9202 actually had nothing to do with the dose schedule on question A. 9202 did show that that there's a difference between 4 months and 28 months for most of those subgroups. Actually, the overall survival was not different in any statistical sense. So the correct answer is going to be D, and I'll show you why. So start with a quote. I picked this up in the New York Review of Books, which I regularly read. It's called, "It's difficult to see what is genuinely new. Harder still to admit ignorance in the face of it." So we've got a few things today that I'm going to throw at you that I think really are new, and hopefully will get people to change some of their thoughts. I'm going to talk about a couple of broad themes, some external beam data, some brachytherapy data, and some ADT data as it relates to radiation oncology. So I'm going to start by talking about normal tissue toxicity. Some of you may be aware of the hydrogel spacer that has been marketed. This is a slide from the European trial that they did when this was first under development. And you can see on the left a prostate and a rectum. As a radiation oncologist, I look at this, and the separation between that prostate and that rectum means a lot, because that space is where I have to thread the needle with my radiation beam. It's where you have to cut, but when you're cutting, there's a nice tissue plane there. For me, that tissue plane is meaningless, and so I need some way of protecting the rectum when I'm treating the prostate. And in the middle slide, you can see injection of some gel. It is only visible on an MRI. You can't see it on CT, which is the left-sided image. But it's pretty clear to anybody that that rectum and that prostate are now separated, in this case, by 11 millimeters. And that's exactly what we need, in theory, to reduce our rectal dose. The slide on the far right shows that 6 months later, it's gone. And I will tell you, in the US pivotal trial, the middle slide, 100% of the time, it was there 3 months after the injection, and in 6 months after the injection, 100% of the time, it was gone. So within, again, trying to show you things that are really hot off the press. This is, again, within the past couple of weeks. European study is now mature. They've followed their patients and have 5-year data, and I just wanted to share that with you because for a patient population that looks kind of like what we normally see, and treatment volumes, that's what the PTV is, that are kind of like what we normally see. There's a substantial drop in rectal dose when you put that little space in between prostate and rectum, and the volume that receives 70% of the dose, you can see, drops from 32% in an untreated patient to 20% in the patient with the gel. And that makes a difference because if you look at moderate bowel urgency, moderate loss of control, or moderate bowel habits, and here we're talking all rectal toxicities, and we're not talking GU stuff. It is a significant difference that is both clinically significant and statistically significant. And I always like to point out, urologists like to tell me that their patients don't have any incontinence. Radiation oncologists like to tell me their patients don't have any late toxicities. But in fact, 7%, 14%, depending on what question you ask the patient, moderate or greater GI toxicities, and that can be ameliorated with a little gel injection. So that's one that I think you should be on your radar. Even if you're not doing it right now, you probably will be seeing it in the near future. RTOG 0415 has been recently published. It's now out in the JCO, and again, I think everyone should be aware of this trial because this is part of a major trend that is happening in the world of radiation oncology, which is fractionation. Some of you may be aware, breast cancer patients historically were 6.5 weeks of radiation. It's now 3 weeks of radiation in your more enlightened centers. Prostate cancer, the same thing is happening, and people need to be prepared for it. So they took a cohort of patients that had low-risk prostate cancer. They stratified them by their different risk factors and what kind of radiation treatment they had. It was a non-inferiority design to the trial. They randomized them between 2 dose schedules. And basically, as urologists, what you care about is not the dose, but the number of weeks. And so 8.2 weeks, that's your typical course of radiation. That's what most patients get, 73.8, plus or minus a few fractions, versus 28 fractions. This is a schedule that Pat Kapalian published when he was at the Cleveland Clinic a number of years ago. Single institution, looked pretty good, but no comparator group. So here it's 1,000 men randomized between these two with follow-up that is almost 6 years. And as you can guess from my excitement, this is actually a non-inferior treatment. So in all respects, in all the outcome data points that they looked at, there's no advantage to going 8 weeks over going 5.5 weeks. The only advantage is it keeps the clinic schedule busier. But it doesn't do a lot for the patient. And from the patient's perspective, these are indistinguishable curves, completely non-inferior. So we know that giving fewer fractions has the potential to change the landscape of what we're doing with radiation and prostate cancer. And I say, watch that space. It's going to be happening. It can happen in any clinic anywhere in the country today. Some people are pushing this envelope even farther, have been doing so for a number of years, and are going to what we call extreme hypofractionation. Extreme hypofractionation is a full course of prostate cancer treatment delivered in about 5 days. There is basic laboratory data, theoretical data based on what radiobiologists call the alpha-beta ratio. Don't don't worry about exactly what it means. But the alpha-beta ratio is how we measure the impact of larger or smaller doses of radiation on a particular tissue. And basic laboratory data says that for prostate cancer, we might be better with larger fractions. And there's mouse data that suggests that larger fractions are biologically more effective, that slow the rate of progression and reduce the likelihood of metastasis. You radiate a tissue, you implant it into the mouse. It won't metastasize if subjected to large doses of radiation as much as it does with small. So there's some theoretical advantages, and there's some human data that is starting to come out that is really showing not superiority, but at the very least some equivalence, and I think that's exciting. Some of you may know this as the CyberKnife. CyberKnife is a brand name of a machine that delivers high-dose radiation. We sometimes call it stereotactic body radiation therapy. SBRT is the acronym that you'll see. Sometimes people call it stereotactic ablative radiation, or SABR, because people just like to have great acronyms. CyberKnife data, you'll generally see it referred to as CyberKnife from institutions that use the CyberKnife. They like to promote the brand name, and I've got to admit it is one of the most sexy names that people have come up with for a treatment device. But this is out of Staten Island. Dr. Katz has published a number of times on his experience. 500-man, fairly long follow-up now. He was bolder than I was, has a lot of higher risk patients that I perhaps would have shied away from at the beginning. Gave 35 to 36.25 gray as his dose in 5 daily fractions. And for the radiation oncologists in the audience, this is the expansion that he used. And when he looks at either dose level, it really doesn't seem to make much of a difference. The biochemical disease-free survival is really comparable to anything that's been published for more conventional treatments. This was not a comparison of SBRT versus conventional radiation, but this is kind of very provocative and some would say hypothesis generating. Sunnybrook has done the same thing. They call it SABR. They don't like to. They obviously don't have a CyberKnife. They have 114 patients. They followed 102 months. This is a poster that was presented at ASTRO just a few weeks ago, looking at their biochemical failure. You can see this one's going up, the other curve came down. But in fact, 5% 8-year recurrence rate is pretty good for a population that is mostly low risk, and we'll acknowledge that. But I think it's worth noting that, and again, you probably can't read the slide, but there are a fair number of studies out there, and I show you this in a table just so that you realize this is not just 1 or 2 outliers that are doing something funky in their neighborhood. There's a lot of studies that have started to do this, a fair number of patients, and pretty similar dose schedules. The outlier in terms of dose is Zimmerman at the bottom. He treated in 9 fractions, and I'll tell you, in any stereotactic treatment that you see that gave 9 fractions was done outside the United States. We have some billing issues that require, if you're going to get paid for it, it's got to be 5 or fewer fractions, and that kind of constrains what people are testing. But in fact, around the world, there are schedules that are out to 10 fractions that have been hypothesized as the right dose. But there's really nothing that says the higher doses, higher total doses are better. But there is some theoretical data that says the higher daily doses matter. Quality of life, again, comparing one dose of SBRT to another, no particular difference in quality of life at a number of endpoints. Dr. Katz, as I said, looked at some high-risk patients, and obviously high-risk patients don't do as well with any treatment. These were probably 14% of his population had hormones. I assume that was overwhelmingly in the high-risk group, but I don't know that for a fact. But he looked at high risk, and there was another poster at ASTRO just a couple weeks ago telling us that other people are looking at high-risk patients with SBRT. So again, this is coming. There are a couple of multi-center trials, the FASTER and the Saturn, that are looking at treating not only the prostate, but the pelvic lymph nodes. So you give 40 gray in 5 fractions to the prostate, you give 25 gray in 5 fractions to the pelvic lymph nodes. I have not had the nerve to do this yet. I wouldn't recommend this for most people in most clinics at this point. This is not anywhere near standard of care, but this is absolutely what people are thinking, and I think it is just part of that larger trend of fewer and fewer fractions. And again, if there's any radiation oncologists in the audience, the V20, the volume of rectum that received 20 gray, if it was over 55 cc's, correlated with a significant risk of rectal toxicity. As you can see from the curve in the middle, there's a big separation at that V20. So if anyone wants to be doing this, which is, again, I don't recommend doing this off trial right now, but the V20 matters. UCLA has been doing this for a number of years, but they have relatively short follow-up in this really high-risk group that had pelvic lymph nodes treated with SBRT. But again, very encouraging results out of a couple groups this year at ASTRO. I expect we're going to be seeing more follow-up on these populations. I expect we're going to be seeing more data. This hypofractionation thing is real. It's not just a couple of guys out in the wilderness doing something different. ASTRO, AUA, and ASCO have together worked on a guideline. This guideline is either right at the end of the comment period or is just closed, I'm not sure. I can't tell you what the guideline says. It says not for distribution, dissemination, because the guideline is unapproved. But these 3 organizations are putting their stamp on a guideline that deals with hypofractionation, that deals with this low-dose hypofractionation, 28 fractions, and the high SBRT kind of fractionation. So take a look on the AUA website, take a look on the ASTRO website, the ASCO website. This is going to be out there within probably a couple of months. And where guidelines go, hopefully clinical practice follows, and I think we're going to be seeing some changes in what's happening in your communities. For those who've wondered, it probably keeps you up at night wondering, I've heard about a PSA bounce with brachytherapy, I've heard about it with external beam, I wonder if it happens with SBRT. Well, in fact, it does. Now you can sleep well at night. RTOG 0232 was presented at ASTRO last year. It was published this year, and so people have had an opportunity to look under the hood and see what this is all about. 0232 was a trial looking at brachytherapy. And for many years, we had a school that said intermediate risk prostate cancer needs combined modality. They can't have external beam because external beam, they can't have seeds alone because brachytherapy alone is not good enough. They need external beam along with their brachytherapy. And under the leadership of Dr. Prestige, RTOG 0232 set out to answer that question. They did a non-inferiority design again. They compared 2 arms, intermediate risk patients who had brachytherapy, some with, some without external beam. It was randomized. It was a really well-done trial with central dosimetry, and you know, I was a participant in this. We had to jump through a lot of hoops to keep patients on this trial. Freedom from progression was absolutely non-inferior. There was no difference in terms of outcomes for the brachytherapy patients, whether we added external beam or not for this intermediate risk group. The biochemical failure, again, whether you looked at the Phoenix definition or the ASTRO definition, there was no difference whatsoever. They're going to be doing subgroup analyses on these. This is the whole cohort. They're going to be breaking out by PSA, by Gleason score, and all the things that are in there. But for now, this is what we have, and I think it's actually rather compelling because I think this could put the nail in the coffin of the combined modality for at least low intermediate risk patients. It looks like the patient population in the PROTECT trial who actually had either surgery or radiation, and I think that kind of gives it, it passes the smell test. They looked at adverse events, and there are indeed, as you may know, more acute and in particular late toxicities amongst the patients who had combined modalities. So not only is it's not inferior to do brachytherapy alone, and you reduce your risk of late toxicities. And column on the, just to show you what you guys are most concerned about. This is any this is, I'm sorry, this is GI, this is GU. And you can see a substantial difference in toxicities between the two arms based on whether they had external beam. 12%, 7%, 53%, 36%. So there's really no question in my mind. We're at the point where we should no longer be offering combined modality to intermediate risk patients. And that brings me to the ASCEND trial. The ASCEND trial was presented at the ASCO GU meeting maybe a year and a half ago, 2 years. It was presented at ASTRO. It's been talked about quite a bit. It's finally in print, and again, you can take a look at it. There are 2 articles in the International Journal of Radiation Oncology, Biology, and Physics. I'm sure you all subscribe to it. The ASCEND trial was done to answer the question that has been nagging at a lot of us. When we first started doing IMRT, I remember having my urologist come to me and say, these intermediate risk patients, these high intermediate risk patients, maybe we should be doing IMRT because you can do that now and we don't have to deal with the side effects from the brachytherapy. And so I think a lot of the world started doing this and started shifting towards IMRT instead of offering brachytherapy as we had done in the 90s and early 2000s. So they did a simple randomization. They said, well, in this era, we got to do dose escalation. Patients need high doses. So everyone got 45 gray to the pelvis, and then they got a boost. And the boost was either done with external beam or it was done with brachytherapy. And in all patients received a short course of hormone therapy. These were high, intermediate, and high-risk patients. So this is a different population than was eligible for the RTOG 0232. These are people for whom there's limited data, although my own data suggests they may not need the external beam. There's limited data that looks at these patients without the external beam. So the external beam is kind of standard. So do they need the brachy, or should we just do the whole thing with external beam? And in fact, when they looked at this, all the endpoints showed a difference in biochemical control. I mean, all the subgroups for all the patients, for intermediate and for high-risk patients. These were not only statistically significant, these were visually significant. These numbers actually look a lot different to the eye. It's not like a new drug where there might be a 5%. I think this is a fairly compelling study, and it's really hard to ignore. The overall survival was not different among the populations, but that may change with time. Are you surprised by this? Well, you shouldn't be, because in fact there have been other studies that have looked and shown similar results in single institution studies. This is a matched pair done by Dr. Pickles up in Vancouver. Very similar outcomes for all low risk and intermediate risk. The National Cancer Database was queried a number of years ago, and they looked at brachytherapy alone or external beam plus brachytherapy versus external beam alone. And in fact, brachytherapy is superior in every one of these populations. This isn't quite as dramatic as the ASCEND trial, but for those of you who've done any work in the NCDB, there's a lot of noise in that data. The ICER has done similar work and has really, given its seal of approval on brachytherapy. And despite that, brachytherapy is being done less and less over time. And it does boggle my mind, and it's something that as an advocate for many years, I find hard to believe. But this is the data also from the NCDB, so it's kind of it suffers from the faults. But this is the kind of thing that the NCDB is good for. They queried and said, at your institution, how many seed implants are being done? And the blue line represents those institutions over time, going from about 2004, I think it was, up to 2012. The blue line represents those institutions that are doing 12 or fewer cases a year. That's one a month. This line down here is those institutions that are doing 53 or more a year. That's one a week. And you can see that the group that is doing fewer and fewer is growing. And what's really scary is that's also seen in academic medical centers. This is what's happening across the country in our training programs. People are not learning how to do these procedures. And in a vicious cycle, this is probably leading to us doing less of it. It is worth noting the ASCEND trial published a separate paper looking at toxicity. And in the toxicity, you can see, I believe the top one is GU, and this is GI. There is an increase in toxicity amongst these patients. A lot of these patients have a harder time, and that's part of the conversation that I have with my patients when they are being considered for this. It does have more urinary toxicity, and it's inescapable. But what they showed in this trial, and this is incidence, this is prevalence, and the prevalence of late toxicities, meaning many of these patients might have had a urinary stricture, got dilated, and they're better. They might have had a proctitis, and it got better. So these are the people who are continuing to have problems. And when you get out to 4 years, we're at about 8% or so that are still experiencing some toxicities from their treatment, above and beyond what they would have gotten just from the external beam. So the prevalence is lower than the incidence, and the prevalence is really down in low single digits. ED surprised me. You can see right off the bat ED in both the black, which is the dose-escalated external beam, and the red, which is the low-dose rate brachytherapy. Everyone suffers ED at year one. Well, that's not a surprise. They all got 9 months of ADT. But if you look at over time, it's actually not that different between the two modalities, which did surprise me. In the interest of time, I'm going to blow through 0526 quickly, but this was presented at ASTRO again a couple weeks ago. It's looking at using brachytherapy as a salvage treatment for patients who have had failed external beam. Some of us have been doing this for years, and there's a lot of single institution publications on this. This is the first real attempt to do a multi-center trial with central dosimetry and yada, yada, yada. It's a relatively small trial, but based on this relatively small trial, we can say that it seems promising. There's an increase in late GI and GU adverse events that is based on the dose that was delivered. And the treatment efficacy, we don't know, because the statisticians won't let us even look at that yet until this study's matured a little bit. But I want you to be aware that this is out there as one of the modalities. There are a number of trials that have looked at radiation and hormones over the years, going back to the 1980s when they were looking at DES and MEGACE as modalities. And you can see a listing of the big multi-center trials. Well, RTOG 9202 started in 1992, just published their most recent follow-up, again, within the past couple of weeks. The trial gave everybody, these were locally advanced patients. This was the first RTOG trial that allowed, that incorporated PSA in the entry. They all received 2 months of hormones before and during, and then they were randomized to plus or minus 2 more years of goserelin. And this was just published again in the International Journal of Radiation Oncology, and you can see this is for the whole population. The disease-free survival in the upper left shows a statistically significant difference favoring those patients who received long-term, long course of hormone therapy. The distant metastasis-free survival in the upper right, again, statistically significant, favoring the longer course of therapy. The disease-specific survival, a slight difference. It is just barely statistically significant, and the overall survival was not statistically significant. And many of you know one of the earlier studies that looked at 9202, one of the earlier publications, reported on the high-risk group because it looked like there was a trend towards an overall survival benefit in this group. And again, the disease-free survival, distant metastasis. Here you see even more benefit in distant metastasis-free survival and disease-free survival. The overall survival looked like it was getting, pretty close to being significant. The curves have come together. It's got a p-value of 0.08, which, as my statistics teacher taught me, almost statistically significant is the same as not statistically significant. So that's where this stands as of now. There's no statistical significance to this, but it certainly is compelling for all the other endpoints. Late toxicities, GI and GU, almost always, particularly when it comes to GU toxicities, we're in that first 5-year period. You can see in the right-hand curve, the toxicity kind of plateaus after 5 years. It really doesn't keep going up as much. The GI actually keeps going up quite a bit, even after 5 years. It's not your problem, but it does happen. I'm going to skip this set in the interest of time. I'm going to tell you there was a recent study that was presented at ASTRO, looking at a new PET agent. I don't know if that's in one of the other talks later, but the F18 flucyclovine was used as an agent to look at patients who had recurrent disease. Most of these were post-prostatectomy. They had a PSA of 0.6. These are patients that you see every day. And they did a scan to see where the outcomes, where the disease was. And in fact, their primary endpoint was change in treatment. And in fact, based on this, 23% modified the radiation fields, 21% shifted to systemic treatment, and 15% shifted to watch and wait from an external beam. Based on that, they've actually stopped the study because they thought that they met their primary endpoint at this interim analysis. Another study, again, if there's any radiation oncologists in the room, to be aware, this is in practical radiation oncology, they did a C11 PET study on patients who were going to get whole pelvic radiation for prostate cancer. And the dark green nodes are lymph nodes that would not have been in the RTOG-approved pelvic fields. The lighter blue-green nodes are those nodes that would have been treated by the fields recommended by the RTOG. So what this is telling us is that even when we're treating the nodes, we're not doing as good a job as we think, and we may be needing to incorporate some of this sort of imaging in the future to try and plan our radiation fields.